evening, everybody, and welcome to MedStar Health Cancer Network's Knowledge is Power Breast Cancer Webcast. You're watching us on Facebook Live. I'm Jamie Costello from WMAR 2 News, and we are streaming to you live from the MedStar Health Bel Air Medical Campus. There are more people in this tonight than the Oriole game last week. This is incredible. Now, I want everybody just to turn around and look, because we've got the back of your heads right now. So just everybody turn. It's almost like a selfie. There you go. Look at everybody here. All right. I didn't say wave. You did not follow the... All right. Listen, we have a panel of 10 experts right now, and these, we've only had a couple up here, but we have several more out in the audience here. But they have developed and they have taken their entire lives to make our lives better. And they are incredible people that you are going to meet. And they have spent their entire medical careers, their entire residency in making us better for it. And we're going to meet them right now. But first, I want to tell everybody to post your comments and questions. Click a like to be sure to share the post on your Facebook. Friends can join in on the discussion. And we want to hear from you. We want to talk to you about breast cancer. So we want to meet the team right now. And you can remain seated, all right, Doctor? You can get... All right, Dr. Shweti Corinne, who has been here. She's an oncologist, hematologist at MedStar Franklin Square Medical Center, and she sees patients right here in Bel Air, right here. Thank you so much for joining us here, Doctor. Diagnostic radiologist Jennifer Flame is here, affiliated with the Baltimore MedStar Hospitals and Bel Air. Jennifer, nice to see you as always. And here we have Dr. Atsuko Akabai, who is a breast surgeon for over 20 years, right, doctor? 20 years you've been doing this breast cancer. Certified genetic counselor Emily Kaczynski is going to tell us who, why, and when we should seek genetic counseling. She's always, everybody's heard from her before, right? Emily is incredible. She could write a book. And also Dr. Gabrielle Corral from MedStar Plastic and Reconstructive Surgery is a very important role in breast reconstruction following mastectomies. So stay tuned for that. We're waiting for you, doctor. And we mentioned that MedStar Georgetown Cancer Institute, we're seeing new signs all around this campus. And Dr. Abulafi is here with us here tonight. And doctor, I think we can go right to you right now. He's going to talk about the MedStar Georgetown Cancer Institute and the new name here in Bel Air. We have a network of experts, clinical, nutritional support, and rehab. Doctor, can we go to the doctor right now? We'll give him the mic and start talking. Okay. Just tell us about the Georgetown signs all around us.
Yeah, so this is really an exciting time for us at the MedStar Georgetown Cancer Institute. This is a combination or a hybrid or a marriage between what has been a community practice and now combining that with an academic program at Georgetown. This allows us to have the personal touch, the personal feel that you get with MedStar, as well as collaboration with the academic setting that allows patients to be enrolled in pretty advanced clinical trials, take advantage or leverage the opportunity with various advanced technologies, and really give people the opportunity to have the best of both worlds, from the academic as well as the community setting.
Dr. Abulafia, you look good on TV, by the way. That's good. You look like you're on Dr. Oz right here.
It was raining last night.
You are renowned as far as bone tissue and soft tissue. Can you elaborate on that? Why you went down that alley and why we're so lucky to have you going down that alley?
Yeah, so it's actually, I wasn't expecting that question, but it is a pretty personal story in the sense I was interested in orthopedics. I was interested in sports medicine and orthopedics, and I realized that they were mostly healthy people, and it wasn't a collaborative thing. You took care of people, you did your surgery, they went home, and everyone did well. And in oncology, what appealed to me was there were patients with real problems where you could really impact their lives, and that it wasn't an individual activity or an individual sport. It really was a team effort that we collaborated with the medical oncologists, the radiation oncologists, the imaging people from radiology, plastics and reconstructive surgery, dietary. It really was what appealed to me.
All right, thank you, doctor. All right, let's start with Dr. Kurian. Let me ask you something right out of the box. You have a lot of women right out here. Can breast cancer be prevented?
Sure. You cannot stress the importance of certain things that can help prevent breast cancer. One, of course, is exercise, daily exercise to keep a healthy weight. And you're talking about moderate exercise of 150 minutes every day, or 75 minutes of vigorous exercise every day. Cutting down the amount of alcohol. If you look at guidelines, they'll say 1 alcoholic drink per day for a woman is probably the most you want to take. Anything beyond, you're talking about 2 to 3 drinks a day for a woman increases the risk by 20% of developing breast cancer. So those are probably 2 most important things. Diet, making sure you keep a healthy weight is probably most important. Postmenopausal weight gain is linked with increased risk for breast cancer. Also, understanding what is your family history. Who had it, who didn't have it, can impact your risk, and discussing that with your physician. Probably you can talk about some other things to help prevent breast cancer. You could talk about some medications that can cut down your risk if you've had certain changes in the breast.
And I'm sure everybody out here, how many of you, I know it's personal, have known somebody who has had breast cancer? Look, does everybody get breast cancer? Is it just a matter of time?
So no, not everybody gets breast cancer. The risk increases, of course. It depends, if you're a woman, definitely. Men tend to get it less, but it's not like they don't get it. It also is age dependent, younger women lesser. As you grow older, the risk goes higher. It depends on we discussed about the family history. So if there are multiple people in the family who had different types of cancer, especially related to breast cancer, colon cancer, prostate cancer, they might have a higher risk.
Youngest patient you've ever seen?
With breast cancer in 30s.
Oldest, first time?
91.
91?
Yes.
Imagine that news. All right, thank you, doctor. Let's bring in Brooke. Brooke Sawicki is a registered dietitian who works with the oncology team at MedStar. And you mentioned about you mentioned about your diet and eating right. Can that help prevent breast cancer, Brooke?
What's most important is consuming a diet that's full of vegetables and fruit. The American Institute for Cancer Research actually recommends this new American plate, which is 2/3 of fruits, vegetables, and whole grains, and then 1/3 of animal protein. The animal protein, we want to steer closer towards chicken and fish, and limiting our red meat consumption to about 18 ounces a week. And you need to keep in mind that a standard serving size for meat is about 3 ounces, so that's about the size of a deck of cards. So just keep that in mind while you're serving your meat, that you are aware of the portion size.
There's only so much stuff we can do with fish. What are you going to do? What are you going to pull out of the bay now? What do you find that's really good? That really works. I mean, salmon?
I love salmon. I eat it multiple times a week. I eat chicken all the time, like ground turkey, incorporating that into meals over ground beef, things like that.
No red meat.
Trying to limit it as much as possible. There still needs to be a lot more research on the topic, but for now I would kind of stick to the guideline of about 18 ounces a week.
Do you eat your Brussels sprouts?
I do.
Carrots? What
Carrots aren't
kind
my
of vegetables like nobody thinks of?
There really is no limit. Any kind of vegetable you see in the grocery store, I usually recommend sticking to the outside of the store, focusing mostly on the produce and the fresh fruits and vegetables, but if necessary, frozen are just as good. They are picked at prime season and then frozen, so they do have the same nutrient value as well as canned goods. Just want to make sure that you rinse them first to get rid of some of that extra sodium they're packed in.
How many times a week do you eat at Chick-fil-A?
I don't.
Oh, yeah.
I want to.
Okay, we all do. All right, let's bring in Emily now. Emily, prevention is key. What about the risk factors that you cannot change, the risk factors?
With genetic mutations for breast cancer, you can't change that. You inherit these genetic mutations from your parents. However, knowing you have that mutation is so powerful because if you know you're at higher risk for breast cancer, we can start screening earlier. We usually start at age 25 rather than the recommended age 40 when most people in the general population start. We also add in a breast MRI, which increases sensitivity for breast cancer. And then women can also think about preventative options like removing the breast or having a bilateral mastectomy, which reduces their risk by over 90% for breast cancer.
How soon can we get like a family tree of our genetics? How soon can we work that? That would be great if we get a map right out of the hospital. Here you go, here's the map.
Yeah,
Here's the
no,
Google.
that's so true. I always tell patients that the greatest gift that you can give to your family is to keep, so they have to do an intake when they come to see genetics and they have to draw out their family tree. So I said, make copies of this and give it to all your family, because over time, people lose track of who's had cancer and what types. And if we see certain patterns of cancer in the family, like breast along with ovarian cancer, it really raises our suspicion that there could be a genetic mutation. So it's so important to know your family history.
All right, you're a hit on Facebook Live because Paula in Aberdeen wants to ask you, when is the right time to bring the family in to come see you?
So that's a good question. I think it really depends on the individual patient. So some patients, when they're recently diagnosed with breast cancer, want to come in right away to talk about genetic testing, because if they have a mutation, they would be at higher risk to get additional breast cancer in the future. With the BRCA mutations, BRCA1 and BRCA2, they were the most common cause of inherited breast cancer. We see up to a 50% chance of getting a second breast cancer after a woman has already had her first. So she may want to have testing even before her breast cancer surgery, because she may elect to have a bilateral mastectomy or both breasts removed rather than just the one affected with cancer. But for other families, it's too much to know right when they're diagnosed.
All right, Emily, you're hot right now. Here's an audience question here. My mom and aunts all had breast cancer. What is my risk and my daughter's risk?
So that's a hard question to give a number, but definitely would be increased with that family history. It would be important to know the ages of diagnosis, because the younger breast cancer happens, the more we think about genetic mutations. And also, when we do genetic testing, we actually like to start with someone who's already had cancer. It sounds backwards, but the reason is we need to see if can we find a mutation in that person with cancer that would be helpful, and then we can test the rest of the family.
All right. Did she answer those questions correctly? Everybody know? Yes, yes. All right, knowledge really is power. Let's go to Dr. Flame, who is going to explain diagnostic radiology. Take us through it.
All right, so I see lots of women in our audience that are probably in the screening mammogram age range, which for the general population, lots of our listeners hopefully are going to be in that 40 and above range. And the American College of Radiology and Society of Breast Imaging are recommending yearly mammography starting at age 40. And a common question I get about screening mammography is, when do you stop? And there is no hard stop. We all age differently. There are some women at 60 years old that may have a life expectancy of 2 more years. Likewise, I've seen some women at 85 that could easily expect to live another 10 or 15 years. So I try to tell people that there are 2 factors they should think about to continue screening mammography. And that's if they think they have 10 good years of life expectancy. I think that's reasonable. And if it's actionable. If someone is not going to do anything about it, then that might be something to consider and talk about. So you come in and you get your screening mammogram. Lots of us know what that's like. I evaluate those every single day and look for anything that might be a disturbance or an abnormality that I would need to look at further. Those women get a letter, they get contacted to come back for additional imaging. And then we do what's called a diagnostic mammogram. And a diagnostic mammogram is, we think there may be a problem. Women can get diagnostic mammograms because we see an abnormality on their initial mammogram, or they can come to us with a problem. They feel something, they're having discharge, they're having redness or pain, something that we need to evaluate. So we do a different set of imaging to evaluate those areas more closely. There are other tools that we use in medical imaging, such as ultrasound, which is an excellent tool. We use it very frequently in breast imaging. It's just another way to look at the tissue. It uses different physics. We see things very differently, and it can help us to really figure out what's going on when we see an area of abnormality.
Let me ask you a question. When somebody comes in to see you and goes into one machine, should they keep going to that one machine? Or should they go to the one machine and then, we're going to go to the next machine over here? Should they be consistent on the machines that they use?
In terms of the same mammogram unit?
Yeah.
There are very strict guidelines, and we do quality assurance techniques every day to make sure that our equipment is up to snuff. And that's pretty universal. Everyone has to kind of go through the same standards when you're in a screening protocol, because we know that the majority of women that we're seeing, they don't have breast cancer. But we have to check a lot of women to find as many of those cancers early on when they are treatable, when we can reduce the amount of morbidity and mortality from those cancers and give those women the best quality of life that we possibly can.
Let's go to Dr. Okabe. Tell me, mammograms, how you know how important they are in detecting this.
Oh, absolutely. That's a very good point, because by the time you can feel a lump in the breast, it's already been there for a number of years. And so in order to catch breast cancer early, where you have the most options of treatment, as well as, of course, the best chance for cure, it's so important that you follow breast screening. And I agree with Dr. Flame. You know, women 40 years and older should get annual mammography.
Okay, and you know, it's always in October because of Breast Cancer Awareness Month that we get different guys. Oh my God, we got to go in when we're 12. You know, they change the rules all the time. But you're saying 40 is that's it. That's the key one, right? Go in at 40. Let me ask you here, we got Lisa Solomon just speaking in here. Can you speak about women with dense breasts that have to follow up with ultrasounds, and are they more likely to get breast cancer? This is from Lisa.
When I read a mammogram, there are certain words that I have to use, and that's so that, say you move to, you know, God bless, Hawaii, somewhere wonderful, so that if you get your mammogram there, it's consistent, so that we're all using the same words, so that you get a similar quality of care, so that you can follow up on something that is an annual exam. So when I first look at someone's mammogram, the first thing I assess is how much quote-unquote breast tissue, meaning the glandular tissue and the fibrous components, are there versus fat, which is the other normal thing that occurs in a breast. There are 4 designations. Heterogeneously dense and extremely dense are what we call kind of increased breast density. Most women will have what we call scattered breast density, meaning, you know, there's not quite as much of that dense breast tissue there. And what we know is that having dense breast does incur a slightly increased risk of cancer. It also makes cancers more difficult to see because on a mammogram, which is, you know, it's an X-ray, it's shades of gray, cancer shows up as a whiter looking mass or entity, but also that background glandular tissue is also white. So it can sometimes be like looking for one snowflake in a snowstorm.
We had, how many ladies and gentlemen, we should not exclude the gentlemen, but when you go out and you look for deodorant, do you read the label, and does that worry you about breast cancer using deodorant? Yes, yes. Is that a worry we should have about picking out somebody even asked online here on Facebook Live, is deodorant a worry?
Not that I have much data. No.
To my knowledge, occasionally in lymph nodes that are sampled, there have been traces of aluminum found in some lymph nodes, but I don't know of any definitive research that would say that there's a direct causative link.
Okay.
All
right.
If you have a non-aluminum option, sure, give it a try.
All right, Teresa Ann Lewis, I've recently been diagnosed with a cyst in my breast. Does that increase my risk of breast cancer?
If it is a simple cyst, then no. Complicated cysts or anything other than a simple cyst, you know, obviously I can't make a definite designation without seeing it, but in general, a simple cyst, meaning there's no solid components, does not incur an increased risk of it turning into something else.
All right, Dr. Kurian, once a patient is diagnosed, what is the first step to determine what's best for that patient? First step.
When you're diagnosed, I think the first step is pathology, looking at the tumor, what type it is, what it looks like under the microscope. Is it an invasive cancer, or is ductal carcinoma in situ, or what are we looking at? Depending on the pathology, you also look at whether it has the protein receptors on the surface, which decides what treatment the patient's going to get. You're looking at estrogen receptor, progesterone receptor, and a HER2 receptor. That actually decides what type of medication you're going to use to have an effect on the tumor. You also look at the size of the tumor. You look at if the lymph nodes are involved. You look at the patient themselves, what they can tolerate, what can be done, what treatment is best for them. So you actually have to personalize treatment for most patients. You have to look at the genetic makeup of the tumors, and that can help determine the risk of this tumor coming back or the risk for recurrence. So a lot of thought and a lot of information goes in before we decide what to do and how to treat a patient when they're first diagnosed with breast cancer.
Out of 10 breast cancer patients, how many are the same?
Well, if you put all the multiples together, I don't think every person is unique, and that's why I said you have to personalize.
Right.
Yes.
All right, let's go with the LEPEP. You want to talk about lymph node dissections, doctor? You want to talk about that, and also breast conserving? What is breast conserving?
When a woman gets breast cancer, if it does spread somewhere, the first place that it will usually spread to is to the lymph nodes in the underarm area. So we call that the axillary lymph nodes. And this only pertains to invasive breast cancer. So invasive breast cancer means that instead of just being contained inside the duct or the lobules, the cancer cells have gone through the wall of that structure. And when it goes through the wall, those cancer cells can then enter into the bloodstream or into your lymph stream. And more often, like I said, it will go into your lymph stream and then travels to the lymph nodes. And since lymph nodes are part of your immune system, they will try to trap cancer cells for as long as it can before it lets it spread and goes deeper into the body. So lymph node evaluation is a very important part of staging breast cancer. And fortunately for us, instead of always going to what we used to do, which is an axillary node dissection, taking out 10 to 20 or more lymph nodes from the underarm, when it is early stage breast cancer that's diagnosed, we will do sentinel node biopsy. And this is a way of assessing the first few lymph nodes that lymph fluid flows to. And if those are negative, we know that they're not going to skip and go to deeper lymph nodes. When we talk about lymph node dissection, in most cases we are performing what's called sentinel node biopsy, which is done at the time of either lumpectomy or mastectomy. But if cancer has already spread to the lymph nodes, then sometimes, and I would say most of the times, we will do an axillary node dissection, which is removing more lymph nodes.
Isn't it neat to be smart? I mean, wow, thank you, doctor. What? We'll bring in Dr. Del Corral here. Thank you for joining us here tonight. You're going to tell us about lymph nodes because these little glands can cause a lot of trouble, can't they, doctor?
They can. Thank you for your question, Jamie. You know, lymph nodes really are, as I mentioned before, they have that autoimmune effect, but they also transfer and helps us transfer fluid from one compartment of your body to another compartment. So when the lymph nodes are removed, in the case of a lymph node dissection or a sentinel lymph node, it can cause a problem known as lymphedema. Lymphedema is really that accumulation of fluid that can that can drain on the extremity. It limits that drainage from that lack of lymph nodes, and that becomes a problem for the patient after having a diagnosis of breast cancer. And there are certain options that we can talk to the patient depending on their degree of lymphedema and their stage to see if we can improve surgically their lymphedema.
All right, doctor. We have a question here. This is a toss-up question here from Jackie Anderson. What advice do you have to offer to those who are afraid of yearly mammograms due to exposure? Who wants that question? Ray, I would imagine, yeah.
So the degree of radiation with annual mammography is really relatively low when you think about background radiation, which occurs all the time. You know, if you take a transatlantic flight, you get a fair amount of radiation. And the benefit to that is obviously hopefully some vacation. If you're talking about your mammogram, you're getting this tiny dose of radiation, and the benefit is really the possibility to save your life.
Absolutely.
So to me, it's a risk. You know, there is some risk. Of course, there's a little bit of radiation, but the risk versus benefit there, it's definitely there.
I think it's something very important. You know, we're talking about some real tough situations, but we do have some great breakthroughs going on for those of you watching. Breakthrough treatment that's really only available in a handful of facilities around the country. And doctor, you're going to talk about one of it. It's a VLNT surgery.
We call it a vascularized lymph node transfer, which is just a fancy name for just grabbing healthy lymph nodes from one area of the body and placing them in the area where they were removed for cancer purposes. There's also another less invasive procedure known as a lymphatic bypass. And just as you reroute the traffic jam on a highway, it allows you to reroute the traffic jam on that lymphatic circulation and help that extremity or that arm or leg to decompress from the lymphedema. So it really depends on what the patient needs and what stage the patient is.
Are second opinions recommended for a cancer diagnosis? You got it? I want a second opinion. You okay with that?
Obviously, yes. I would say absolutely.
Absolutely.
No, I think having cancer treatment is a huge step in a person's life. So you want to make sure that you feel comfortable not only with the physician that you have met, but also you want to know that what was recommended for you is appropriate. And by having a second opinion, I think you are able to get that information.
Okay, all right, we're going to bring in Dr. Camilla Nowak-Choi, who is a radiation oncologist. And doctor, can you tell us about radiation therapy and how this all works?
Sure, absolutely. So I think in radiation oncology, just like in any of the specialties taking care of breast cancer, the key is really a personalized approach where you consider each patient as a unit, as a unique individual. So just like with other specialties, when I see a patient for consultation, there's not one size that fits all in terms of the radiotherapy that's recommended. But you look at all of the patient's characteristics as well as the tumor characteristics before talking to them about recommendations of the specific type of radiation that they're getting, both in terms of the extent of their radiation as well as the length of their radiation. So that's one of the keys. And I think something else that's very important that we've been focusing more and more is also looking at the potential side effects from radiation, not just in the short term, but also in the long term, and utilizing techniques that will decrease the risk of damage to normal tissues, which is something that there's definitely being a big push in the field. For example, protecting the heart.
All right, Dr. Choi, thank you. Dr. Del Corral is a plastic surgeon with the Georgetown Cancer Institute at MedStar. Doctor, can breast cancer patient get implants after breast cancer? Can they?
It's a good question. Yeah, absolutely. They can definitely get an implant after breast cancer. And it's actually the most common way of performing breast reconstruction in the United States. The one important thing is to make sure that that implant gets some kind of surveillance. Usually we recommend an MRI after having an implant reconstruction, and our Society of Plastic Surgeons recommend that MRI to be performed at least every 3 years for the first 3 years, and then after that every 2 years. So it's important to remind yourself that you have an implant in your body that is going to need to be monitored for the rest of your life.
And reconstruction options. There are a number of them out there, right?
Absolutely, but primarily you can divide them in an implant reconstruction, or you can use your own tissues, and the tissues can come from different areas of the body. And we're really trying to find the best way and the best fit for that patient, depending on their aesthetic goals, and really if they have the ability to take the time off from work, and how do they see themselves, 5-10 years from now, to decide which option would be best fit for that patient.
Okay. I want to ask you, what is it like to sit across from a patient to tell them that they have breast cancer, and then to tell them that they're cured? The two scenarios from start to finish. Tell me about that. Or is there one patient out there that will always stick in your mind on how it looked bleak, but man, they see the sunrise tomorrow?
Whenever there is the diagnosis of cancer, it's unnerving for anybody, whether it's a small cancer, big cancer, it doesn't matter. Whether younger patients have different things they worry about, and older patients have different things they worry about. For me, what makes it comfortable telling them this news is I know there are options to treat. They're very good options. The likelihood of curing somebody with early breast cancer is very, very high, over 90%. And so those are some things I can tell the patient, make them feel comfortable that if they do the right things, if they follow the guidelines, if this thing is done, if we provide the treatments that is appropriate, the likelihood of this thing getting cured is very, very high. And once they're done with treatments, yes, of course, sitting in front of them and saying that I think your cancer is cured is probably the best thing as a physician can feel, because that's a very, I don't know if I can explain that feeling. It is that you were able to do what you worked for this while, and the patients, the way they feel when they hear that, yes, it's cured, and it's probably not going to be something hanging over my head all my life. There are patients who walk in at age, as I said, older patients who walk in, and if they are 90-some-year-old, discussion is different. The discussion is sometimes how I want to cure this for you without making you uncomfortable. And I know of some of my patients, or one of my patients who had walked in with a lot of problems, and in the end when we were able to do and complete everything, I said it's all done and you're free, and I'm seeing her 3 years out from it. Yes, the 91-year-old 3 years out from it doing well. That's an amazing thing. Yes.
That is amazing.
Yes.
I want to go back to Dr. Del Corral, who you're going to describe the Diep Flap reconstruction. Diep Flap.
Sure. So it's primarily an advanced way of doing a tram reconstruction, which is the way we used to take tissue from the abdomen. In the past, we used to take the tissue from the abdomen to reconstruct the breast, primarily taking someone's muscle. And for those patients who had a double mastectomy, you can imagine the amount of recovery and pain that those patients can have if both muscles are removed. So the Diep flap is the more modern or sophisticated way to do this surgery.
How long has this been going on?
You know, it's really a technique that has been going on since the early 90s.
Really?
And it's been, changed over the last 10 years to really limit the dissection to just take the skin and the fat and the little tiny blood vessels and spare the nerve, the muscle, to make sure that that patient doesn't develop a problem in their abdomen, make sure that that patient has an easier recovery. Because we're really replacing tissue like with like. You're removing the breast tissue, which is technically a subcutaneous organ, and using your abdominal tissue to reconstruct that breast.
It's like liposuction, and then instead of discarding it, we're going to use it.
Exactly. It's a good way to use that abdominal tissue, put it into good use.
Holy cow. All right, doctor, you're in the business to cure us. What's it like to tell that patient, you're going to make it, you're going to survive, you're going to make this?
It's almost indescribable. And I can think of one particular patient, and there are so many. There are so many patients, but there are so many individual patients, and I remember all of them. But I remember a patient that I saw here my first week, and she knows who she is, and when I tell this story, she'll really know who she is. Yeah. But I saw her a year ago at Disney World. And it was like the greatest reunion of all time. They set off fireworks over the castle. That's how it feels inside, to see that person out there doing exactly what she wants to be doing with nothing holding her back. That cancer diagnosis, that's in the past. She was at Disney World. We were having a great time. That's the only way I can think to explain it. Sorry, I have small children, so it all comes down to Disney World.
Good. And doctor, you've been around the block a time or two. You started out. Tell me what it was like to start out 20 years ago to today, and the technologies and the advancements and the cures that we're seeing that we may not have seen 20 years ago. Tell me about that.
That's a really good question, and I would say that's one of the reasons, the advances that occur in breast cancer, that keeps me really engaged in this field. Because every year when I go to my annual American Society of Breast Surgeons meeting, there is some new something being discussed. So when I was in residency, most women were getting mastectomies and not getting immediate reconstruction. So yes, there was an option for delayed reconstruction, but you had to wake up with that drastic change in your body. Very shocking. And for the lymph nodes, we were not doing that lesser surgery that I described earlier, which was sentinel node biopsy. We were automatically doing axillary node dissection. And what studies showed is that for over 60% of women who were getting axillary node dissection, there was no involvement of the lymph nodes. And yet, by taking so many lymph nodes, they were going to be at higher risk for developing lymphedema and such. So what I've seen over the years is less invasive treatment. So for the lymph nodes, sentinel node biopsy. And then for the breast surgery itself, most women are going to be candidates for what you had mentioned earlier, which is breast conservation therapy. So breast conservation is conserving or saving the breast. So even if you have breast cancer, it does not automatically mean that you have to have removal of the breast. Most times you can have a lumpectomy, which is just removing a part of the breast where the cancer is. Lumpectomy, however, does almost always go hand in hand with radiation therapy. And that's another thing that I've noticed too over the years is radiation therapy used to be just one way, that's it, that's all, taking about 6 weeks or 7 weeks. Now even the daily treatment is down to about 3 to 4 weeks. And sometimes we have these other options like doing a one-time radiation in the operating room, which is called intraoperative radiation therapy, before the woman even has woken up from her lumpectomy and lymph node surgery. We have already done that radiation treatment. Or there is another kind where the treatment can be performed in 5 days. It's just been a progression of less traumatic. Yes, it's a difficult diagnosis, but I think with all the advances that we've made over the years, we have such a variety of options that we can discuss with our patients. And I think one of the things that is so key is the early diagnosis. When you have been having screening mammograms, and I would like to throw out there breast self-exam, because there's a lot of controversy, do you do it or not? I am still a very strong proponent for breast self-exam, because I still have patients who come in who found something because they felt it.
How often?
It's not that often. I would say that for, if they're getting their mammograms, to be missed by mammogram can be maybe about, 15%?
Very low.
Yeah, maybe even lower than 15%.
Okay.
But you can also have what's called interval breast cancer. So we mean, you've been having your regular mammograms, but before that year has come around for your next mammogram, you start to feel something. So if you have a more aggressive cancer, you may detect it that way.
How often? A week? Once a week? Every day in the shower?
For the self-exam?
Yeah, for the self-exam.
I
What would
usually
you advise?
recommend once a month.
Once a month?
Yep.
Okay.
And for women who are having periods, the best time to check is 1 week or so after your period.
After, okay.
Because as you're approaching or during your periods, your breasts are more swollen, more tender, more lumpy, bumpy, so you can get false alarms.
Okay. Lumpy bumpy. There you go. That's good.
Very
Emily,
medical.
I want you to take me down your career path. Why genetic testing? How did that reach out and grab you? What attracted you to this?
I think what really got me into genetic counseling is just the ability to, dig into people's family histories and be able to help them, understand maybe why a disease or condition happened, and be able to give them power to know that information and possibly start earlier screenings or, preventative options, or just to get a better understanding of why the same condition, keeps happening. And also on a personal level, my father had a genetic condition in his family, and just, they didn't really understand why it was happening, and, but through genetic testing, it really came to light. So I think, those combinations of just how our DNA, our genes, shape so much about us, and sometimes it's really important to look at them and, see if cancer or maybe other conditions are inherited in the family.
Do we skip several? Have you seen several generations skipped, or have you seen?
So genetic mutations don't skip in a family. You have to inherit them from a parent. But let's say you get the genetic mutation from your dad for breast cancer. He may not have developed breast cancer because his risk is pretty low. He could possibly develop prostate cancer because that is a much higher risk in our BRCA-positive and other breast cancer mutation families. So it may look like it's skipping, but that the dad had the mutation. It's just that he may not have shown signs of it, but he can pass it on to his daughters and his sons.
What do you see in the future of genetic testing? What do you see down the road? Tell me what you would like to see.
We're already starting to see more genes that we can test. So I've been mentioning, BRCA1 and 2 is the most common cause of inherited breast cancer, but now it's routine to test over a dozen genes related to inherited breast and ovarian cancer. And I've had a couple families that I saw, a few years ago, and they came back to do expanded testing, which was looking at a larger panel of genes, and we actually got a mutation that we didn't pick up before. And now, that patient's daughter got tested and she has it too. And now we better understand her risk, and she's going to pursue preventative options. So it's so powerful because before we think it's genetic, but we can't pinpoint it. But now with this additional testing, we are picking up more families.
All right, Dr. Okabe, somebody wants to know what a Save Scout is.
Oh, Save Scout. Okay. So that is a device that we can use when you're doing a lumpectomy. So when we're doing a lumpectomy, we have to know exactly where the cancer is. And there's different ways to know that. If you can feel it, that's fine. We know where to do our surgery. But if you can't feel it, then we need to have some roadmap to show us what part of the breast needs to be removed. The more common way, and the way it's been done for many, many years, is a needle localized lumpectomy, we call it. So on the day of surgery, you go to the radiology department and a skinny wire is placed. Now there are different devices that have come out. So actually on the screen, I'm seeing a picture of a Save Scout, and that is a special marker that is based on radio frequency. So you put that marker into the tumor, and instead of having to have a wire tell us where to go, we use a special probe that they're showing here to show us where the tumor is. And by doing that, we know exactly where to cut and where to remove tissue.
Hey, just like that. Look at that. And how long does that take?
Oh, I think not long. I mean, Dr. Flame has put those markers in.
We put those in moments. Just a few moments.
Just like that.
Yeah.
All right, Dr. Del Corral, seems a lot of people find out that there is a treatment for lymphedema are shocked And explain what the lymph node transfer is
Sure.
again.
So a lymph node transfer, it's really taking lymph nodes from one area of the body and place them in the area where the lymph nodes were removed. And they work through different mechanisms. The primary mechanism is that they really work like little sponges where they're going to absorb that fluid. And they have little veins within that lymph node, and they actually are able to excrete that extra fluid that they're absorbing through their own vein to improve that arm or leg. That's how a lymph node transfer works. And there's different ways to do it, and not everybody's a candidate. Perhaps if you have an early stages of lymphedema and you have some improvement with your massage and your therapy, perhaps you may not need surgery. And all of these surgeries are really not a cure for lymphedema. They're primarily an adjunct to lymphedema therapy. So you really need a patient who continues to see the lymphedema therapist, and it's really a collaboration of the two specialties to improve and have a good outcome. If the patient may have an early stage of lymphedema, we can do a very non-invasive technique where we can go into the arm or the leg, and we can make about a 1 centimeter incision, and we can connect maybe a 1 millimeter lymphatic into a 2 millimeter vein to help drainage. And that's using special technology as well.
How'd you get into this?
So plastic surgery is always, I love the field because it's really, specifically for breast cancer, you're not really, you are really creating something that was removed completely out of almost nothing. And after you create it, you have to make it match an opposite side perhaps. And you have to make it, it's very artistic the way to give that outcome to that patient. And I love about that because every day is a new challenge. And I love that. There's really no monotony in what I do.
Wow. Brooke, I want to go back to Brooke. See, I caught you right here. Brooke, do you go nuts with all these studies that we say on TV if you drink wine, 2 glasses of wine a day, if you eat garlic all the time, no Italian would have breast cancer so what are the hot foods right now that everybody's garbling down to prevent breast cancer?
So a lot of the things that you just mentioned are mainly phytochemicals. So there is a lot of research on the phytochemicals and cancer protection. They are ingredients found in wine, in garlic, and fruits and vegetables. That's what give fruits and vegetables their flavor, their color, their odors, and they collect free radicals in the body, which reduces carcinogens and cancer forming in your body.
All right, good. Let's go to Dr. Kurian. Facebook question, after breast cancer, can a woman still have a baby?
Yes, it depends on how old you are, and of course,
when I go to med school now.
And depending on how early, I mean, if you sure can have kids after you've had breast cancer. So you should have finished your therapy. If you had cancer that early and you finished your hormone therapy or whatever therapy you had, then yes, you can have kids after that. But for certain types of cancer, pregnancy can increase the risk of having the breast cancer again. So you have to be monitored very closely.
How often do you all talk to one another?
All the time.
Every day. Yes.
Every day.
Time. Yes.
Do you really?
Yes.
You share?
Yes.
You say, can we do it? Do you all meet at once with a patient sometimes?
Yes. Sometimes.
We do
Yes.
have.
Talk about that, because I think that is, instead of making 19 appointments, let me just come up and sit down in front of everybody now.
Perfect. So we do something called a multidisciplinary
Love
clinic.
it.
So a patient comes in with a diagnosis, Dr. Akabi will get in touch with us and say, hey, we have a patient, we need to discuss, would it be possible? And me as a medical oncologist and radiation oncology will meet with the patient at different times on the same, one after the other, give options in terms of treatment, so they get a composite picture of what their treatment would look like. So when they leave this place, they have a clear understanding of what it would mean going forward, how to treat this and how we could take care of it.
What's it like to see fear in the face of a woman who's just been, they're thinking of their kids, they're thinking of their husband,
Yes.
they're thinking,
So, no woman ever wants to be told that they have breast cancer. It is a very difficult news to take. But what I try to tell the patient is that because most of these women are diagnosed with early stage breast cancer. And I think it's very important for them to know up front they're going to survive this cancer. Yes, this is a blip in their life right now, but you're going to get all the best up-to-date treatments that you can possibly have, and it's probably never, ever going to be an issue for you. It still doesn't take away the fear. I think it helps to let them know this is probably not what's going to kill you. In fact, every time I go on the American Cancer Society website, the number of breast cancer survivors in the US continues to climb. And right now, I think we're approaching like 3 million breast cancer survivors in the US.
Also here, please explain Pageant disease and how common is this? This is from Patty, who's watching us on Facebook tonight. Pageant disease.
Paget's disease is a special type of breast cancer. It's not very common. And this is where the ducts inside the nipple are affected with cancer. It is in situ cancer, meaning it's not invasive, but oftentimes it can present with, some people say like a rash of the nipple area, and as time goes on, you will have flattening of the nipple. So when a woman is doing breast self-exam, I think that's one of the things to look for are changes in the appearance of the nipple.
And doctor, give me some hope. Give me some hope. What do you see down the line?
Well, I see that we are able to detect things much sooner, where we don't have to go through aggressive treatments, where screening can detect cancer much sooner, earlier, and or we can implement things that prevent cancer from developing at all. I'm not sure how we're going to reach there, but that's the aim. Right now, I think even if we have a diagnosis of breast cancer, there are excellent treatments. There used to be a time where cancer treatments were very, very aggressive. People were sick. There were floors where used to be cancer chemotherapy floors where people would be throwing up all the time. And that's what everybody associates with cancer care or cancer treatments, not just with breast cancer, any other cancer. And that has completely changed. People tolerate treatments well. The newer treatments are much, much more tolerable than they have been in the past. The outcomes are much better. And as I said, most people will survive their breast cancer and have long lives. So.
That's good. You give me hope. All right, Emily, here we go. We got the question here. At age 16, I had a benign tumor removed. My mom and aunts have had breast cancer. What are my risks? I think you hit this one. That's a similar question that we had earlier, right?
Yeah, so definitely we would, be concerned about that family history, having 2 family members with breast cancer. But breast cancer can also be familial, where there may be, common exposures or common lifestyle factors that's making that family a little bit higher risk. So there may not be a genetic mutation. So it'd be important to gather information, how old were the women when they were diagnosed with breast cancer, make sure that there's no other types of cancer in the family. We think more about genetic mutations with ovarian cancer, prostate cancer, pancreatic cancer. So gather all that information and then ask your physician to see a genetic counselor who can really sit down with you and go through the family history and give you a better sense of, could it be genetic? And then we can also calculate the lifetime risk that that person would develop breast cancer, based on not only the family history, but their personal risk factors, hormonal factors like when they got their first period, when they had their first child, and really personalize their risk assessment. And they may qualify for increased screening starting earlier or adding in breast MRIs. So there's a lot that can be done with a genetic risk assessment.
I want to go back to Dr. Abalafia. I've known you for a long, I've been a big fan of yours forever. How do you know clinical trials? How do you know you're ready? How do you know you're primed for a clinical trial?
Well, it's, the word we like to use is multifactorial, which just means there are a lot of variables that go into making that decision. When I initiate a conversation with the patient about clinical trials, what I try and do is the first thing I tell them is this is completely voluntary. And I follow up with the statement, because patients frequently want to please their doctors. So I tell them, I'm not going to like you more if you do it. I'm not going to like you less if you don't do it. So I really want it to be an independent and informed decision.
But not everybody fits, right?
Absolutely. So if they don't fit into a clinical trial, then that's not an option. But then we go through what the clinical trial involves, and we want to make sure that we're not exposing them to an inappropriate risk, and that they understand it, and that it's been vetted through a whole group of researchers, ethicists, statisticians, and that it's something meaningful.
Jennifer from Abington is asking about fibrocystic breast disease. She has it and her mother has it. Increased risk?
Typically not, no.
Jennifer, that's great news for you from Abington. That's great. And also, Pablo from Forest Hill asks, this is it, when are you considered cancer-free?
Some of the cancers, like the ER/PR positive, which have the estrogen and progesterone receptor positive cancers, they have they don't grow as quick. Their chances of recurrence are less, but they tend to linger around for a long period of time. So you need to follow those patients. You have to follow for a longer period of time to say you're cancer-free. But generally, you consider a 5-year period after which the risk of recurrence is lesser. For some of the other cancers which don't have the receptors, which are triple negative, they don't have the ER receptor, they are more aggressive up front. The risk of recurrence is higher in the beginning few years, but as time goes by, the risk of recurrence or the tumor coming back goes down. So yes, 5 years is considered to be, but because of trials, as when you tell the patient you're likely cured of your cancer.
Let me go back to Dr. Choi. You've seen so many advances, like every day. What do you see when you're 91? What are we going to see? What do you see down the line?
I think the big focus is really focusing on which patients need the radiation and which patients are such low risk that they may be able to get less radiation or even no radiation at all. And so a lot of the trials are focused on teasing out these patients. And the other thing is, what I mentioned before, is really protecting the normal tissues. We know that the radiation does have a benefit in terms of decreased recurrences, but we also know that some patients may have some secondary issues because of the radiation. And so all of the techniques and the advances that we focus on is trying to minimize those side effects in the long run as much as possible.
Tina from Aberdeen wants to ask you here, what is linear accelerator, and is that the best option for radiation treatment?
Okay, that's a great option. So a linear accelerator is basically a machine that generates the X-rays or the radiation that we use to treat patients with external beam radiotherapy. It's the most common form of radiation that we use for patients with breast cancer. There are some patients that are candidates for something else called brachytherapy, which is basically a treatment where the radiation is actually introduced through a device that's placed in the lumpectomy cavity. Not all patients are candidates for that, so it's basically a case-by-case scenario. But the linear accelerator is the machine that's used in most scenarios.
All right, let's go, and this is our final wrap-up. Dr. Del Corral, how proud are you of your profession now? Seeing what you're seeing, listening to what you're hearing tonight from very great experts.
Very proud. I think we have made tremendous changes in the field. And I think plastic surgery is going to continue to evolve tremendously. So it's very gratifying to what we do. And I think over the next several years, what we're going to see is a tremendous change in doing not only less invasive surgery, but we're also going to have more adjuvant treatments, such as fat grafting, for example, after you're having some mastectomy. I think implants are changing all the time and getting a lot better. And we're doing more advanced techniques now that are going to have better outcomes and going to have less recovery time for patients, and they can go back to their normal activities much faster.
Okay, Emily, brag a little bit. Tell me about the good things happening in MedStar. Come on.
Okay, I can do that easily because there's so many good things happening at MedStar. Yeah, so I think something that I'm really proud of in talking to my colleagues in genetic counseling is just how much respect that the team gives me and refers patients to me, because at some centers, physicians will do their own genetic testing and not value genetic counseling, and that there's a lot that goes into the decision to have genetic testing. Do you want to know? What are you going to do with the information? Does your family want to know? And I'm just constantly impressed with how much the team, will just look to me and refer patients, and I get them in as soon as I can if needed. So I want to give a thank you to the team for just respecting what we do, and our role is becoming more and more important, not just for the families, but the patient. I mean, sometimes it determines their treatment. A certain type of chemotherapy might be offered, if we do find a genetic mutation.
All right, doctor, you've got the rooftop. Shout up 95 and down 95. What do you want us to know?
I think what I would like, people to know is how closely we work together. Not only on a day-to-day basis. We have a multidisciplinary conference that we have every Thursday, and all the patients that are either, in some cases, newly diagnosed or who have had surgery get presented. And we have a group of breast surgeons, medical oncologists, radiation oncologists, radiologists, pathologists, and as a group, we discuss every single patient and follow national guidelines and come up with the best possible treatment for that person. What Dr. Korean mentioned earlier is that one person's breast cancer is not another person's breast cancer. We are so personalizing the treatment these days. And what we found is that all these different features of a particular cancer not only may give us an idea of prognosis, but it helps to direct our care to give them the best possible treatment.
Doctor, from Disney World, you're in another Disney World. We're on a ride for our life, aren't we?
Yeah.
What a ride.
Yeah, we sure are. I think, I'd like to speak to how great a job that MedStar has done in making sure that we have the most up-to-date technologies here from a radiology perspective, having 3D mammography, having breast MRI available, having, high-quality ultrasound available, having the capability to biopsy a lesion under all those modalities here in Harford County is fantastic, but even more than that, something that I'm exceptionally proud of in this group and in this organization is that it's incredibly human. I get a chance in my day to talk to every patient that comes to me for a diagnostic mammogram, and they're terrified, and we see it all the time. And they don't just talk to me. They will talk to me, but they talk to my staff, they talk to my mammographer. They go right next door and talk to Dr. Okabe's staff. We go behind our little secret back trap door and we talk to each other. And I think that really shows, and I can see from the start of a new patient to the end of our visit when they go over to Dr. Okabe's office, there's a visible difference in the stress level in these women when you treat them as they are. They're individuals with dignity, and it can be embarrassing and a stressful experience, and I'm really proud of the way that MedStar handles it.
Doctor, I take it you don't just treat the patient, you treat every person behind that patient, the family, everybody.
Absolutely. Every patient that walks in is not just a patient. They have a family, they have work, they have others who are concerned about their health. When they come in with a lot of knowledge or not so much knowledge. My job is to tell them what you have, how to treat it, and make them feel comfortable that it's okay. It's okay to have an aggressive diagnosis like breast cancer. And it's okay because we have a great team and excellent treatments to take care of things. Every day, as Dr. Okabe, Dr. Flame, and everybody here says, we talk, we discuss, we come up with a plan for that patient. And it's not just about the cancer part of it. We have a team that involves a social worker who will talk to the family and say, okay, you are having problems, you're having these issues, how can we manage this? You're having transportation issues, how can we bring you? How can we make sure that you come for the things that you needed so we take care of this cancer and take care of your family? It's not just the diagnosis, it's not this is the treatment and you're done. It's taking the patient in a whole and making sure they feel fulfilled when they're done with this treatment that, okay, I not just took care of the cancer, I took care of my family, I took care of other things that need to be taken care of while going through this aggressive treatment.
Well, we love you all, but we don't want to spend the night. So we're going to, but weren't they great? I think everybody should give them a round of applause for what we've been through and what we're going to go through and what we're going to come out on the other end. It's going to be great. Thank you so much for joining us on Facebook Live. Thank you for your questions. And again, thank you from Bel Air tonight. Beautiful downtown Bel Air. We'll see you again. Thank you again for watching.